Cek. Udah langsung dimulai, Dokter? Oke. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, Profesor, Dokter semua. Salam sejahtera untuk kita semua. Good morning, our respected Professor and Doctor. Selamat datang kami ucapkan pada acara Kuliah Pakar bersama dengan Dr. Lloyd dengan tema pagi hari ini adalah Current Perspective of Corneal Transplant. We welcome you to the expert lecture with Dr. Lloyd with the theme is Current Perspective of Corneal Transplantation. Before we proceed with the agenda today, we would like to express our sincere gratitude to Dr. Lloyd as our guest speaker from Duke Eye Center, Durham, North California, USA. Marilah kita buka acara ini dengan membaca basmalah bersama-sama. Let us begin this session by reciting basmalah together. Bismillahirrahmanirrahim. Baik, kita langsung masuk ke acara yang pertama, yaitu kata sambutan dari Kepala Departemen Ilmu Kesehatan Mata kepada Prof. Dr. Muhammad Bayu Sasongko, MEP PhD Spesialis Mata, kami persilahkan. Now let us hear welcoming speeches from our Head of the Ophthalmology Department, FKKMK UGM, to Professor Dr. Muhammad Bayu Sasongko, Magister Epidemiology PhD Spesialis Mata. The time and places is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for coming, Lloyd. I won't be long. Just quick welcome to you. We are very pleased and very thankful for you to come here and share with us your experience in the form of lecture. And yesterday you had surgery with us. So this morning we welcome Dr. Lloyd William, who is going to share with us his experience. He's a corneal specialist from Duke University with thousands of hours of experience of corneal surgery. So if it's a pilot, we measure it by thousands of hours of flying. So yeah, here I'm sure you have thousands of hours of corneal surgery. And yeah, he is very experienced corneal specialist from Duke University. We wish to collaborate in the near future with you, not just this time, but also we wish to have a continuing collaboration with you. And this morning and this afternoon continued with surgery at our theater. And yeah, we please share with us, and we're very welcome.
Terima kasih Prof. Bayu atas kata sambutannya. Thank you, thank you Prof. Bayu for the speech. Sekarang kita akan masuk ke dalam acara selanjutnya, yaitu pembukaan dari sesi kuliah pakar oleh moderator. Kepada Dr. Muhammad Nafis Sabara, spesialis mata, kami persilahkan. Now we enter the next session, the opening of the expert lecture by the moderator. To Dr. Muhammad Nafis Sabirin Mara, spesialis mata, the time and place is yours.
Thank you, Dr. Mati, as our Master of Ceremony for today. The Honorable Head of Ophthalmology Department, Professor Bayu Sasongko, Medical Doctor PhD, the Honorable Professor Agus, the Honorable all of our staff at Ophthalmology Department, and our resident doctor, and our speaker, Dr. Lloyd William. Welcome, sir. Nice to meet you again. Who is it going today? Yeah,
it's good.
Yeah. Okay, fine. And all of these distinguished participants, good morning. Assalamualaikum warahmatullahi wabarakatuh. I'm Nafis. It is a great pleasure and honor for me to be a moderator for today's event. And first of all, I would like to welcome you all to this expert lecture. And for your information, this lecture is conducted in a hybrid setting. So we'd like also to welcome the participants who are joining us virtually. Thank you very much. Well, as we know, corneal blindness is still an issue for people around the world. About 8 until 10% of total blindness are corneal related, and the further problem is limiting of corneal donation supply. Then if there are corneal donation, how effective we utilize them to treat corneal blindness, which is still challenging for us. Hence, in this occasion, we would like to have a lecture. The topic is current perspective of corneal transplant. Hopefully, after this meeting, we can absorb a lot of knowledge and experience from Dr. Lloyd. Now, let me introduce our speaker today. He is Dr. Lloyd Berthold William, Medical Doctor PhD from Duke Eye Center, USA, an expert in corneal field with a lot of experience. Maybe we can present the curriculum vitae of Dr. Lloyd. Yeah. And currently he has been an assistant professor of corneal division, chairman of global ophthalmology division, and also a corneal fellowship instructor at Duke University, Duke Eye Center. He is also a young research professor at Moran Eye Center and a chairman and the board and founder Help Mercy International. He did his PhD at Tufts University, and then he had his residency at Moran Eye Center, and he also did his fellowship on cornea and refractive surgery at Johns Hopkins University, Maryland, and he received a lot of awards and a lot of international journal publication. He does about 700 corneal transplant every year, so his experience is no doubt. Once again, welcome, Dr. Lloyd William. Thank you very much for being here with us. After that, Dr. Lloyd is going to give the presentation for about 45 minutes. Is enough for you? Yeah. Following that, we are going to have question and answer session after this presentation. Without further ado, I would like to invite Dr. Lloyd to deliver the presentation. Dr. Lloyd, time is yours.
Thank you. Thank you all for inviting me to Indonesia. It's my first time in Indonesia, so it's quite exciting. Although I have told people several people that, as a child, I lived in Papua New Guinea, which is not too far from Indonesia. So I've at least been in this part of the world. I wasn't 100% sure what the knowledge level of everyone here was going to be. So I did some relatively basic slides as well as some more complex ones. But I wanted primarily to leave some time for questions and discussion so that we could, so that we could deal with the topics that you guys are most interested in, since I've never been here and seen what you do. I'll talk a little bit about what Duke Global Ophthalmology is and where we work and what we do, and then get on to talking about cornea transplant. These are some statistics that it depends a little bit on where you read, but roughly 36 to 45 million people in the world are blind. Quite a few more have moderate to severe visual impairment. And this, primarily in the world, that's cataract. That's about half of it, but corneal disease is a major portion of the blindness, as Dr. Nafis said, about 8 to 10%. And treating corneal blindness has been quite difficult in many parts of the world, primarily due to lack of tissue. So the Duke Ophthalmology Department asked me to help them start the Global Ophthalmology Program. And so we're reaching out to different countries in the world to try to help establish eye banking, to try to teach corneal transplant techniques, and to also try to work with cataract surgery. Obviously, M6 is a big part of cataract surgery, so I trained in Nepal with Bidya Pant. You guys probably at least know Sandrak Ruit, who trained Bidya. And so I had a great experience learning M6 with them. We don't do a lot of M6 in America, but at Duke, I do still do M6 on patients who come in with white or Morgagnian cataracts or other things like that. But I do quite a lot of M6 in Africa and some other parts of the world. The red dots on this map in El Salvador, Honduras, Sierra Leone, Zambia, South Sudan, Nepal, and Indonesia now represent where Duke Global Ophthalmology has been working. So the dot in Indonesia is new as of a couple of days ago. But what you can see on this map is the more red a color a country is, the higher the rates of blindness. Now this is age standardized prevalence of blindness. The country that has the most in the world is South Sudan. And I was just there in December, and we did 2,000 cataract surgeries in 2 weeks. And there are probably about 100,000 cataract surgeries that still need to be done. But you see that Indonesia is actually in the next tier of where the blindness rates are still really quite high. And because the population of Indonesia is quite large, it's the fourth highest population of any country in the world, that represents a lot of blindness that needs to be treated. So our first location where we began working with cornea transplants globally was Sierra Leone. And you can see in the image of the surgeons, that's Dr. Jalika Mustafa, who is the first Sierra Leonean doctor to perform corneal transplants. And we did those surgeries in 2021, but have been back several times and have now done a total of 52 cornea transplants in Sierra Leone, about half of which were performed by Sierra Leonean doctors, and about half of which were performed by me. Almost all of those transplants were penetrating keratoplasty, and we'll talk a little bit about why that is. To do corneal transplants in global settings is actually quite challenging. In the picture on your top right, that's me going through the airport at John F. Kennedy in New York City, packing the corneas, putting them on ice, trying to get the customs agents to not take them away from you, trying to get through the baggage screening without having the corneas x-rayed, trying to get them on the airplane because they want to put them in the hold in the checked baggage where they'll freeze. So they have to be actually on the plane. Sometimes they don't fit in the overhead and you have to get them in the coat closet and so on is really quite a challenge. And you never really know when you're going to have a problem. So in bringing the corneas to Indonesia, we had no troubles in Raleigh-Durham, where I live, getting out. Then the customs agents in New York City told me that I would have to wait 5 days to get clearance from them, which obviously is a problem. By then, most of the corneas would have expired. So there, in order to get through, I had to let them run it through the X-ray scanner, and then also open up the box and take every single one out and show them all of them, and then put them all back in and re-ice it and retape it. And then in Korea and in Jakarta, there were no problems again. So you just never know. It's quite a challenge. The picture below that is the cornea all the cornea transplants we did on one trip. And the child on the other side is a child with a limbal dermoid, which we don't see a lot of in Duke. But as you know, a lot of times those patients may need a patch graft because the dermoid may be full thickness or nearly full thickness. And so above is the child before and below is the child after surgery. And we were able to do that with the cornea tissue we brought. These are just pictures from South Sudan, patients after cataract surgery. So that's the other major thing we do as Duke Global Ophthalmology is get involved in manual small incision extra cap and teach as well as perform those surgeries around the world. And in places like South Sudan, many of the patients are light perception or hand motion only in both eyes. And then it's really quite a joyous experience in the morning to take off all the patches. So cornea transplantation worldwide, there are about 185,000 transplants per year worldwide, and about 284,000 corneas procured worldwide. More than half of those corneas are procured in the United States and in India. And the United States is actually now a major exporter of corneal tissue as well. And developing corneal transplantation and eye banking in various countries is really quite difficult depending on the legal structure of the country. So Dr. Eddie and I and others have talked about this a little bit. In the United States, one of the ways we are able to generate a lot of corneal transplants is when you get a driver's license, you have to choose, do I want to be a organ donor or not? So anybody who's had a driver's license has either elected in or out of organ donation. And then there are so many organ donations in the United States that most people either know someone who has received one or know about somebody who's received one. So there's quite a bit of openness to being an organ donor in the United States. And so many people choose to be organ donors. So there's a pool of probably 100 million individuals who are potential organ donors in the United States because of that system. And then when a patient dies, for some reason, you don't have to go back to the family and try to get consent in that moment. The consent has already been provided, which makes it a lot easier, particularly with grieving families and so on, to not have to broach the topic of, hey, your son just died, do you want to donate his organs? A lot of people don't want to have that conversation in that moment. Now, the legal structure there in the United States that allows that to happen really promotes transplantation, but in other countries, the laws that would allow that, or like in South Sudan, the number of people with driver's licenses is actually quite small. So each country has its own challenges, and usually those challenges involve more than just building eye banks, but are related to the legal and social structures around organ donation as a whole. And one of the really nice things about working on corneal transplants is a lot of times as you develop the structures that allow for corneal transplantation, it actually benefits kidney transplants, liver transplants, and all the other organ transplants as well, because the legal system required to procure and use transplants is very similar across organs. Worldwide, about 60% of the transplants are penetrating keratoplasty, or full thickness transplants. In the United States, it's now less than half. So the majority of transplants in the United States are lamellar or endothelial. Just a brief overview of those. Penetrating keratoplasty, full thickness transplant sewn in. Anterior and deep anterior lamellar keratoplasty are also sewn in, but don't remove the patient's decimase and endothelium. Decimase stripping automated endothelial keratoplasty is a transplant of decimase membrane, endothelium, and a small amount of stroma. And DMEK is just decimase membrane and endothelium. And you might say, why or when do we choose one versus another? The top three and the bottom two are quite similar. And so for me, you know, why would I choose a DSEK over a DMEK? We'll talk about that. But in general, what I would say is DSEK is technically simpler. And so you don't have to see as well to do a DSEK. DMEK is technically more challenging. So I tend to do DMEKs on otherwise healthy eyes and DSEKs on sick eyes that have had a lot of surgery, have glaucoma tubes and other things in them, and can be quite complicated. So my fellows, when they see DSEK on the surgery schedule, they're always afraid because they know the eye is going to be a mess and it's going to be very difficult. When they see DMEK, they're excited because then they think, oh, I'll get to do this surgery. So this is data from New Zealand. I couldn't find the graph of the data for the United States, but it's quite similar. So ignore the numbers on the side, but because the numbers in the United States would be much higher. But this shows sort of over time that that penetrating keratoplasty has fallen somewhat, and DSEK and DMEK have risen quite a bit, particularly in the last decade for DMEK, as people have figured out better and simpler, more straightforward techniques for doing DMEK. So penetrating keratoplasty, this is a picture of one. I'm sorry, my fellows were supposed to provide me with videos and they didn't, so I'll have to get on them when I get home. So we have photographs, but hopefully many of you will be able to see the surgeries today, where we'll actually be able to do some DSEK, some DMEK, and some penetrating keratoplasty. So the sutures are 10-0 nylon. They're rotated, so the knots are in the inside of the cornea, and penetrating keratoplasty is indicated for full thickness opacities, which can come from trauma, corneal dystrophies, infections. Penetrating keratoplasty sometimes is also useful for perforated corneas. So frequently when we have a patient with an active perforated ulcer in the United States, we will do a penetrating keratoplasty and cut the ulcer out completely and sew a new cornea in. I call that a hot transplant because the eye is hot from the infection. But many of the hot transplants are still actually quite successful, and I have yet to have a patient at Duke who ended up with something like endophthalmitis after a hot transplant. So they do seem to do actually quite well, and frequently the patients feel a lot better because they no longer have the active inflammation from the infection. So frequently people will say, oh, you know, my eye doesn't hurt nearly as bad the day after surgery as it did the day before. And that often gets them on the road to recovery. In particular for acanthamoeba and some of the fungal infections that are hard to treat medically, we will sometimes do a keratoplasty and just cut the acanthamoeba out and put a new graft in. And that can be easier and faster sometimes than treating a patient with chlorhexidine for months. Sometimes penetrating keratoplasty is indicated in patients who have endothelial failure only because the endothelial failure has been there for so long that it has resulted in corneal scarring. So we have several patients here who have pseudophakic bullous keratopathy, but the prolonged edema of the cornea has now resulted in corneal haze throughout. And so penetrating keratoplasty is probably going to get them better vision than just an endothelial keratoplasty. And then the other one for penetrating keratoplasty is severe keratoconus. And we did see 2 instances of pretty significant keratoconus in the United States due to cross-linking and due to scleral contact lenses. We do a lot less transplants for keratoconus, but we still have patients who come in who've had high drops or they have Down syndrome and nobody knew that they had keratoconus, so they come in when it's very advanced and very late. And so we do still do transplants for keratoconus, but just not as many as we used to. DALK, I find DALK technically challenging. I don't know, is there anyone in the room who does DALK? A little. I do some DALK. I would say in the United States we don't do a lot of DALK. There are some advantages to DALK though, in that in a patient who has healthy endothelium, DALK reduces the risk of endothelial rejection to basically 0. And so overall those patients have a lower risk of rejection. The problems with astigmatism and things like that can be the same as for penetrating keratoplasty. And it's not helpful in patients who have a perforation, or usually we wouldn't do it in an infection. But in patients with just stromal scarring and things, a DALK can actually be a really great procedure. Some people do DALK for keratoconus as well. I find that challenging because often they have very thin cornea in one area, and it's easy to perforate in the area of thin cornea. DALK does have the advantage, though, in the developing world, particularly in Africa, where you can use corneal tissue that does not have healthy endothelium as your transplant material. So glycerol preserved corneas, irradiated corneas, and corneas that have no endothelium can still be used as DALK because you're relying on the patient's endothelium. You have to be pretty good at it though, because if you start a DALK and you fail and need to convert to penetrating keratoplasty, but you don't have any tissue that is amenable to that, then you're sort of in trouble. But there are people in India and Africa who do DALK all the time and are really quite good at it. It's one of those things where if you do it often enough, you get good at it, just like DMEC or some of the other more technically challenging surgeries. The other nice thing about DALK is you have lower risk of losing the contents of the eye during surgery. So those of you who were with me yesterday, you saw a pretty interesting penetrating keratoplasty on a 39-year-old girl who was anxious and squeezing the whole time. And so when we started taking the cornea off, iris was coming out of the incision and her lens, and she's phakic, her phakic lens was bulging forward. And so we did what's called a sandwich technique, where I cut a quarter of her cornea and then put a stitch, and then cut a quarter and put a stitch, cut a quarter, put a stitch, cut the last quarter and put a stitch, and now her cornea is held on by 4 sutures. And then I took the donor cornea and put it on top of that with viscoelastic in between, and put stitches with slip knots in 3 locations around that, so that I could then cut the 4 stitches on her cornea, pull it out from underneath, and quickly tighten the slip knots so that her eye is never fully open. Otherwise, I think her lens would have come out of the eye along with vitreous and maybe even possibly retina, which obviously is not a good thing. And so with DALK, because you're not entering the anterior chamber fully, you have a much lower risk of things like that happening because the eye stays pressurized. DSEK was developed before DMEK and is technically simpler. With DSEK, we are now using thinner and thinner grafts, and it looks like the outcomes of DSEK with ultra-thin grafts are actually quite similar to DMEK. And so in some ways, ultra-thin DSEK and DMEK have, I don't think there's a major difference between the two, except for that the DSEK is technically a little easier. I do use some sutures because at Duke we use an inserter called an endoserter. There are a variety of inserters, such as the TAN Endoglide and the Busen Glide and other things to insert DSEK tissue. But you can also insert it with forceps, or like we did yesterday with a bent needle, and slide it in. The DSEK usually is floated up with air, so the bubble in this picture is an air bubble. Occasionally, we do DSEK with an expanding gas like SF6 or C3F8. But typically in the United States, we do DSEK with air alone. And then what we do is we do a complete air fill for about 10 minutes to squeeze any fluid out of the interface, and then lower the eye pressure and make the bubble small enough that it won't cause pupillary block. And so DSEK has really improved pseudophakic bullous keratopathy and Fuchs dystrophy treatment. A lot less risk of rejection, less risk of hemorrhage, less risk of the patient getting poked in the eye and breaking their sutures, which we do see, and is quite a big problem when it happens. And like I had said, DSEK, the thing I like about DSEK over DMEK is in patients who have a poor view into their eye, like their edema is really bad, or they've had a prior penetrating keratoplasty and they're aphakic and they've got holes in their iris and they've got 3 glaucoma tubes in their eye and a giant peripheral iridotomy over here. You can still do a DSEK and do it quite successfully, because as you put it in, you know what orientation it'll unfold. And so if you slide it in correctly, it will unfold correctly every time. Whereas with DMEK, it goes in as a scroll and you don't always know which is out, the decimase or the endothelium. And so if you can't see it, it's really quite challenging to be 100% sure. Now there are new ways of doing DMEK. The pull-through method, which I have not tried yet, but has become popular among some surgeons in the United States, actually allows you to, we call it endo-in. It allows you to inject it partly into the eye and then reach across the eye, grab just the very edge and pull it in, where the endothelium is intentionally scrolled on the inside. And when you use that technique, it will always unfold correctly. Or at least if you do it right, it'll always unfold in the correct orientation. So there are techniques that people are working on to make DMEK technically a little simpler. This is a picture of DMEK. DMEK is, you stain the decimase membrane blue with trypan blue and then roll it up in a scroll and inject it into the eye. In the United States, we usually do that. It usually comes preloaded by the eye bank, sorry, which makes it quite simple. in that, you know, you just take it out, it's already in the tube, you inject it in the eye, and then all you have to do is unfold it. In ideal circumstances, I can usually unfold a DMEC with 2 or 3 taps on the eye. So once you do enough of them, they become really quite simple. And then with DMEC, we almost always use expansile gases. The studies of the different gases, air versus C3F8 versus SF6, showed that SF6 had the lowest risk of the graft not sticking primarily, but that C3F8 was also very superior to air. I think that's because the Decimase membrane wants to roll up, and so having a gas that lasts longer helps keep that open. This is a pretty busy slide. It's mainly to remind me then to talk about sort of post-op management. So people have asked me, how often do we see the patients after surgery? What sort of follow-up do we do? So a typical penetrating keratoplasty at Duke, we'll see them at 1 day, 1 week, 2 weeks, 1 month, 2 months, 3 months. At 3 months, we'll consider doing a pentacam to see how much astigmatism they have. And 3 months is the first time where I might remove 1 tight suture to try to reduce astigmatism. My colleague, Missy Dallavoy, never removes any sutures before 6 months, so there's some variation in how people do that. I won't remove 2 sutures that are side by side, but I will sometimes remove a single suture or 2 sutures paired on either side of the eye to reduce astigmatism if there's a lot. So then we see them at 3 months, then at 6 months, where we really begin working on astigmatism correction. We also work on correcting visual acuity. So most patients after penetrating keratoplasty have some astigmatism. Average astigmatism is about 4 diopters, so enough to affect vision quite a bit. Most of our patients receive scleral contact lenses, or prior to scleral contact lenses, people got rigid gas permeable contacts. But a hard contact will almost always give a keratoplasty patient better vision. And then after 6 months, we usually see them at a year, and then every year after that. At each visit, I usually get a pentacam or a pachymetry, because I believe that if you see the pachymetry slowly increasing, that's a sign that they're having some endothelial rejection, and you need to address that. Many times you can catch that early enough because you saw they went from a thickness of 550 to 570 to 590, now they're 610. You increase the steroids or treat them differently at that point. Before their corneal thickness is 800 and they need a repeat transplant. As far as post-op drops go, we don't usually do, in a straightforward patient, we don't usually do oral steroids, but we do that in high-risk patients. So like a keratoconus patient is a patient who has a very low risk of transplant rejection, whereas a patient with an infectious etiology who now has corneal neovascularization and other things is a patient who's at a high risk of failure. So for a keratoconus patient getting a penetrating keratoplasty, I would use 6 times a day prednisolone drops for the first month, followed by 4 times a day to about 3 to 6 months, and then slowly wean them off down to once a day. I prefer to keep patients at once a day for life because I think it does reduce the risk of transplant failure. But more importantly, it reminds them every day that they have a transplant in their eye and that it needs to be taken care of. And I think one of the major causes of failure we have in the United States, and I think I've seen a few instances of it here in patients who came for a repeat transplant, is that after a while you just kind of forget about the transplant and you stop following up. and maybe there's a suture left that breaks and the tail's sticking out, and it irritates a little bit. You don't think about it, you don't go to your doctor, and next thing you know, you have a transplant rejection. And so by taking 1 drop a day for the rest of your life, every time you put that drop in, you think, I have a cornea transplant, right? So that's one of the major reasons I like to keep people on 1 drop a day. Now, some patients will be steroid response glaucoma patients and things. And so if you have a patient who is having a steroid response to the prednisolone or Lotemax or something like that, then I think it's okay to stop steroids at about a year out, rather than risk causing glaucoma in that patient due to the steroid. So I don't always keep people on steroids, but as long as the steroid is not causing some other problem, I will try to keep them on steroids for the rest of their life. Suture removal, we'll usually try to remove all sutures at 12 to 18 months, somewhere in that range. Because scleral contact lenses are very expensive, we try not to have them buy a scleral contact and then take their sutures out and have to go buy another one right away. So sometimes that governs when we take out the stitches. But about 12 to 18 months is the goal. I think it is important to take out the stitches and not leave them too long, because they will eventually break. And patients that forget about it after the suture breaks will almost always, if they don't come in and have it removed or you don't happen to see them, will almost always end up with an infection, transplant rejection, or both. So the picture on the right here is a picture of a suture sticking out. And you can see how the cornea looks really quite clear everywhere except for where that suture is. And where that suture is, you have corneal neovascularization growing into the suture. You have some lipid deposits around it. And that corneal neovascularization is going to bring the immune system to the transplant. And once there, it's going to discover that it's doesn't belong to the body, and a rejection episode is going to begin. So I would say in our patients, the 2 most common reasons for graft failure are broken sutures, and the second one is people saying, oh, I thought you told me I could stop all my drops. Or I always take the one with the brown top and I threw away the one with the pink top. Meaning they take the antibiotics and they've been taking the antibiotic for a year faithfully, but they threw away the steroid like after a month. And you wonder, how did this happen? You know, we talked about this. We talked about how you're going to be on drops for the rest of your life. We talked about how this one with the pink top is the most important one, and but somehow patients still manage to forget or get confused, or somehow manage to mix up the drops. Partly because some of them don't see very well. I think that's probably a factor, but that's an important, I think those are the 2 main things. So having a system by which you can continually follow up with your patients know that they can get in contact with you if something feels wrong in the eye, and you are very careful to explain to the patients the need for eye drops. I just tell people you're going to need them forever. And then maybe later we'll stop them, but I don't tell them that because I don't want it to get confused. I want them to plan on having drops forever, so that it's unlikely that they'll think, oh, I don't need to take these anymore. So a little bit about the future of cornea transplantation. This paper here by Tabin and Ruit was the paper that first described M6. And so there's a picture of Jeff Tabin and Sandak Ruit. Jeff Tabin is one of the people who trained me, and Jeff and I have been friends for years. We rock climb together, we travel around the world and do eye surgery together. And the development of M6, as everyone here knows, really revolutionized cataract surgery. You know, if you had to bring a phaco machine to South Sudan to do phaco on those rock hard light perception only cataracts, Number one, the outcomes wouldn't be great. Number two, the trips would be far more expensive. You'd have to have electricity that actually works well all the time. And it would greatly limit the amount of cataract surgery that takes place in the developing world, which would have led to a lot more blindness today than because of this. So with cornea, I think there's two main avenues that need to be pursued in terms of curing corneal blindness, particularly in a country like Indonesia, but also across Africa, and to some extent even across the United States and Europe. And those are improving corneal eye banking techniques and improving corneal eye banking access around the world, because as you know, there are many countries who don't have corneal eye banking, and then there are some countries like Indonesia who do have an eye bank, but the number of corneas that are harvested in a given year is actually a quite low number, nowhere near enough to meet the demand. And it's not that easy to transport corneas from country to country to maintain a continual flow to really have a good corneal transplantation program in a country. I think you need to have your own eye banks. But the second one is, and what you see on the other picture is a Boston keratoprosthesis. And we do some of those at Duke. I think people who know anything about those prostheses know that they work okay. They have a lifespan maybe of 5 to 10 years if everything goes perfectly. And then usually once they fail, that's the end for the eye. And so the reasons they fail are typically glaucoma. It's very hard to measure pressure on eyes that have a keratoprosthesis. So most people follow glaucoma just by looking in and following the nerve. It's also, they usually break down at the edges between the tissue and the hard plastic portions of the graft. So very frequently, keratoprostheses will erode in some part and then end up with a open globe or a corneal melt somewhere, and also membranes growing across the eye on the inside are quite common. And so typically Boston keratoprosthesis, which is the major artificial cornea in the United States, typically it doesn't last for that long. Now, if I was light perception only in both eyes and was in no way a possible corneal transplant with human tissue, I would prefer to have a Boston keratoprosthesis than nothing. But if I had my choice, I would want it to last the rest of my life. And so I think the other really major area or the major question for cornea as a specialty is, what is the M6 of cornea? You know, what is going to be the quick and easy surgery that you can do it and then not have to worry that much about the cornea for the rest of the patient's life? And we certainly aren't there yet. And ultimately, I'm not 100% sure how close we are. There are some pretty exciting advances in terms of the endothelial cell only transplants that are being researched, that were developed in Japan, that are being researched across the United States and a variety of other places, where you're, instead of doing a DSEC or a DMEC, you're just purely injecting endothelial cells and then having the patient lay face down for those cells to stick on the surface of the cornea, and you can actually probably replace endothelium. What's exciting about that is you can generate enough endothelial cells to transplant hundreds of patients from one single donor. So as that develops, I think that's going to be a very exciting avenue for, say, pseudophakic bullous keratopathy in Indonesia. because you will be able to eye bank tissue from one person and treat, say, your next 200 PBK patients. And so that'll decrease the amount of pressure on eye banks in terms of corneal transplantation. I think it too may be possible, and I don't know if anyone is working on this, but if somebody wants to work on this with me, I'm all in, is we know that it's possible to take corneas and irradiate them and keep them, say, on a shelf for years. And if you then would transplant the endothelial cells that you just made, just like we talked about with PBK, you could probably do a full thickness transplant with the stroma of a cornea that you've preserved, say, after irradiation, that you've had sitting on the shelf for a year, and then add endothelium to it by injecting cells into the anterior chamber once you've done the transplant. And so there may be, the future may be hybrid techniques like that, or true artificial corneas that act sort of like an IOL, where it can't reject because it's made out of plastic, or better eye banking. And I think at least at this point, it's important that we put effort into all three of those techniques, because it's not clear which of those is going to work out. And certainly the corneal or the artificial corneas and some of those other techniques are years away, and not going to happen soon enough to help a lot of the patients that we're seeing right now. So I didn't want to talk only. I wanted to offer you guys a chance to ask any questions. So it's your turn.
Okay, thank you very much, Dr. Lloyd. This was very comprehensive presentation and insightful for us. Not just about corneal transplant, but also humanity. And now we come to question and answer session. Is there any question from resident? Yeah, please, Dr. Rifa. The person in charge can help.
Thank you very much, Dr. Nafis, Dr. Melati, Dr. Lloyd, for the opportunity. So it's interesting to know that you have a regulation in US that required all the people who wants to take a driving license to be a corneal donor, right? So
not all the people,
not all,
but when you get your driver's license, you're given a choice.
Oh, yeah.
So you're not required,
Not required.
but somebody asks you, do you want to be a donor? And a lot of people say yes.
Okay. So in addition to that, do you have any more screening or how to know that it's the person is a good candidate for corneal donor, and many maybe other examination you have to have a person to be a good donor?
Yeah. So when we have tissue donated, the eye bank itself does an extensive screening, including checking for herpes simplex, HIV, the Creutzfeldt-Jakob, some of the prion diseases, and other types of potential infectious disease that could be transmitted by the cornea. We also exclude patients who have died from causes that could be infectious in the cornea. So for example, if you died of Creutzfeldt-Jakob or a prion disease, then you would be excluded from transplantation with the cornea, because we think that those may be potentially transmissible via a cornea transplant. So the eye bank, when they provide me a tissue, it tells me the age of the patient, how they died, how long ago they died, how long it took for the cornea to be preserved after death, what the endothelial cell count of the cornea is, and then a list of diseases and other laboratory tests that were done on the corneal tissue to see or to make sure that they don't have any of these specific viruses or other diseases. So all of that's quite important. And then if a cornea comes up and say the patient had HIV, then that cornea would not be used for human transplantation, but would instead be used, say, for research or maybe a wet lab or something where it wouldn't be where there wouldn't be a risk of transmitting the infection.
Yeah, thank you very much.
Okay, thank you, Dr. Rifa. How about cancer? This is contraindication for corneal donor?
No.
In America? No.
In general, no.
In general, no. Okay, thank you. Is there question? Oh, Dr. Reny, yeah. Maybe Dr. Reny will elaborate or give question.
Thank you. Thank you, Dr. Lloyd. I would like to ask 2 questions. Our first question is, in Indonesia, especially in our hospital, we have a lot of patients with neovascularization on their cornea. And as your lecture slide, it mentions such as bevacizumab. Maybe you can explain more about how to give that bevacizumab, maybe previous or after the surgery. And the second is, maybe you can explain more about combination from keratoplasty, especially in infectious patient, you can add more such as maybe corneal collagen cross-linking or maybe amniotic membrane, etc.
Okay.
Thank you.
As I talked about and as you're saying, eyes with significant corneal neovascularization are at higher risk of the transplant failing. So how do we manage that neovascularization? And it actually also makes the surgery itself more difficult. When there's blood all over the eye, it's harder to see. The blood kind of gums up the sutures and makes everything sticky. So sometimes the patients will have a hyphema because their iris is also neovascularized from the infection or from some other cause. So all of those don't help the transplant survive. So usually what we've done, and we don't have access to some of the things you do, but usually what we've done is injectable subconj Avastin or bevacizumab, and we do that about 2 weeks before transplant, and then do the transplant and then observe. And sometimes if patients have very large vessels or continuing to have neovascularization, we'll also give some subconj afterwards. And for recently, I had a patient who had a really big vessel, like this big, kind of growing across his cornea and down. And we actually tied that vessel off with a vicryl suture to reduce the. I didn't think it would recede, so we just tied it off to reduce the blood flow from that vessel to the cornea. People outside of the United States have used Avastin eye drops, and I think that actually probably makes a lot of sense, but it's not something that we have access to. So I don't have any personal experience with that. In the complex transplants, such as patients who are neurotrophic or patients who have autoimmune disorders and so on, I do think sutured amniotic membranes are excellent, particularly the neurotrophic patients. If you can get the epithelium to heal faster, that's always better. We do often use oxervate, the nerve growth factor, the human recombinant nerve growth factor eye drop on patients with neurotrophic corneas, and actually try to restore nerve function to the cornea prior to transplant, and then often another dose after transplant, because of course once you've restored nerve function and then you take a cutter and you cut through all the nerves, you've damaged them again. So frequently in patients with neurotrophic keratitis who've ended up getting transplants, we'll use a round of oxervate before and after transplantation, and that's helped a lot in those particular patients. But I think amniotic membranes are great. I use them all the time in patients who at the 1 week visit aren't having good epithelial healing. Like I'd like at a week, I'd like to see that the epithelium is healed or almost healed. If they still have a 5 or 6 millimeter epi defect, then that's clearly they're having troubles healing the epithelium, and I'll use an amniotic membrane pretty much right away when I see that. The amniotic membranes we have at Duke are Procara, the one in the ring, and AmbioDisc, the dried one. But there are also ones that you can suture on, and there are a variety of other companies and such that make amniotic membranes. I don't know which ones exactly you have access to here, but I think amniotic membrane is great. Tarsorrhaphy is great. That can be an excellent way of improving healing. It's something that I should mention is that patients with eyelid disorders, particularly trichiasis or severe ectropion or something like that, those are all really bad for the cornea. And so ideally you would fix any eyelid disorders prior to corneal transplantation. But often, if somebody has ectropion, doing a tarsorrhaphy, like a permanent tarsorrhaphy, will be very helpful in helping that graft to survive. Did I answer everything? Thank you.
Enough, Dr. Reny? Yeah, thank you, Dr. Reny and Dr. Lloyd. Before we go to the next question, I want to say welcome, Professor Suharjo, our head of corneal subdivision. And yeah, Prof, yeah, please, person in charge, yeah.
In our hospital, the majority cause of corneal blindness is infection. How about your experience in your hospital? The success rate corneal transplantation with patient with after infection, it usually is caused by fungal and bacterial infection.
I would say probably about 20% of the transplants we do in North Carolina are for infectious keratitis. And it's not uncommon that it will be fungal, which is something I imagine you guys see here as well. North Carolina is pretty humid most of the year except for the cold winter time. And the more humid environments do tend to make the fungal infections more common. And the acanthamoeba and the fungal infections that we see, if they don't respond to medical treatment quickly, I will almost always do a hot transplant on those eyes and try to remove the infection before it gets into sclera. Because acanthamoeba scleritis or acanthamoeba fungal abscesses in the sclera are pretty much the end of the eye. I have one patient who we managed to save her eye, but it's a pretty dire situation. Or if you get endophthalmitis from fungus or acanthamoeba. So a lot of times I'll try to cut those infections out before they spread off of the cornea into other parts of the eye. Now, as you probably are thinking, if you have a fungal infection in particular, but also acanthamoeba, if you put a lot of steroid on it, it can definitely make it worse. So for fungal transplants, when we do a hot PK in a fungal transplant patient, I will actually do their post-op regimen as cyclosporin 2% rather than prednisolone eye drops. And will maintain cyclosporin as their immunosuppressive until either one, they end up with enough sort of inflammation due to the graft that you have to give them steroid or else the eye is gonna, the transplant may fail. Or usually at about a month or two, I'll switch over to a steroid when you're pretty confident that the fungus is gone. And I maintain them on antifungals for about 2 to 4 weeks at least after the transplant to try to make sure that we didn't miss anything. I have seen patients done by other surgeons who did the transplant, started them on steroids very soon after, and then the fungus came back and ate the whole transplant, and then we had to do another transplant. So, but with cyclosporin, we've actually been really quite successful at getting those patients to do well. Occasionally we go back and retransplant, but even in that circumstance, then that transplant is generally a pretty routine one, and they seem to do quite well.
You use cyclosporin by local or systemic?
Local. So we have a compounding pharmacy make it as 2% cyclosporin.
How about using antifungal as a prophylactis?
We do use antifungals. Typically, I'm using voriconazole eye drops right now. They seem to be a little less hard on the cornea than, say, natamycin. But it depends a little bit on the culture and sensitivities. Sometimes we're able to determine exactly what the fungus is and what it's sensitive to, and then we'll target it based on that. But in general, without other information, I usually use voriconazole.
Thank you, Dr. Lloyd.
And that is a topical. Oral voriconazole occasionally, but usually just topical. If you're using oral voriconazole, you need to check liver function. It can, in some patients, kill the liver, which of course kills the patient, which is not a good outcome from a cornea transplant. The other interesting thing about oral voriconazole is some of my patients have had hallucinations from it. So I had a patient who, some people in North Carolina, they hunt deer. I don't know if you guys know what deer are, but it's kind of like an antelope. And, yeah? Only in the zoo? Okay. Well, they run all over the place in North Carolina, just wild and free. And some people hunt them. So this guy got a fungal infection, and we put him on oral voriconazole. And he would see deer coming up to his house with shotguns, hunting him. That was his hallucination, is all the deer were coming back to get him. So he found that a little disturbing.
Thank you, Dr. Lloyd. Before we move to the next question, is there any question from virtual participant? Dr. Melati, you can help us to read.
Okay, so there's two questions from the Zoom meeting, Dr. Lloyd. So let me read from the first one from Dr. Triwinarti. When do we decide to choose DSEC or DMEC as a surgical treatment for corneal endothelial disorder? And which one has the better success rate? Thank you.
Yeah, so I do DSEC on eyes that have problems and DMEC on eyes that are straightforward. So if you've had multiple surgeries or you're aphakic or the cornea is so swollen that it's hard to see into the eye or the iris is messed up, like somebody with eye syndrome or somebody who's had a trabeculectomy with a very large iridotomy, on those patients, I prefer DSEC. Also, DSEC, we have our DSEC patients lay on their back for 2 days, and our DMEC patients lay on their back for 5 days after surgery. So some patients can't tolerate laying down for that long, and so we'll do DSEC on patients who have back problems or something and can't tolerate it. The DMEC, though, tends to have better vision. So you have a higher rate of patients being 20/20 with DMEC than with DSEC. Most DSEC patients, unless it's super thin or like ultra thin DSEC, most DSEC patients end up about 20/25 or 20/30. And DMEC has a higher rebubbling rate than DSEC as well. So, so in some ways, DSEC is a little bit safer, a little bit easier, less rebubbling, but the visual acuity is a little bit less than in DMEC.
So how many hours do the patient have to lay down every day, or is it 24 hours for 5 days, or maybe just 8 hours is enough?
We usually say that you can get up for about 5 to 10 minutes per hour, or most of my colleagues say that. What I tell people is you can get up to eat, drink, and go to the bathroom, and then the rest of the time you should be looking at the ceiling right above you.
Okay, thank you, Dr. Lloyd. So we continue to the second question from Dr. Andi. Morning, Dr. Lloyd. Greeting from Makassar. My name is Andi, and I have an experience of suprachoroidal bleeding during open sky PKP, and it was a nightmare every night for me. Maybe you have the same experience, and is there any suggestion to prevent that condition? And there's also a message, let's climb Mount Rinjani together someday if you come back to Indonesia.
Yes, definitely on the climbing. For sure, but I did have a suprachoroidal bleeding during an open sky PK. I've only had one. It was about 1.5 years ago, and it was an absolute nightmare. I agree. They're really awful. The patient's retina actually came all the way out, and I was holding it in my hand. And I mean, it's kind of interesting. I've never seen a retina like that. It was, I could see all the way to the ora serrata, I sent it to pathology just to prove to myself that it was retina, but it was, sadly. So suprachoroidal bleeding during open sky PK, it definitely can happen, and it's something that is pretty devastating for the patient and the surgeon. In thinking back as to what happened in my particular patient, the patient's blood pressure became very high during the surgery. So that was definitely a factor. So, all the general risk factors for suprachoroidal hemorrhage apply also in penetrating keratoplasty, but are more magnified than they would be in, say, cataract surgery. But it's all the same risk factors. So people with uncontrolled hypertension, you should definitely control that before you take the cornea off if you can. You can also, another major cause is people having a valsalva or coughing or things like that during their transplantation surgery. So we do a lot of transplants at Duke with retrobulbar anesthesia rather than general, but general anesthesia does reduce your risks of having the patient do something during the surgery that would increase the pressure and expulse the ocular contents. So I would say, managing things like blood pressure, adequate anesthesia so that the patient doesn't move or squeeze or valsalva during the procedure. And lastly, in the patients who are very high risk, you may consider doing DALK or anterior lamellar keratoplasty or something that doesn't actually open the eye entirely. And that would certainly mitigate the risk.
Okay, thank you. Maybe the last question. Is there any question from here? Yeah. Dr. Chakra.
Okay, thank you, Mr. Lloyd, for the opportunity. I'm Chakra from Godean, and I would like to ask 2 questions. The first one, we know that corneal donor is still a social barrier, especially for my region. And then you mentioned about the Boston keratoprosthesis, right? Between the front plate and the back plate, it still use the donor, right? So what do you think about the alpha core soft keratoprosthesis? Is it effective or still in clinical trial? And then the second question, could you explain the effectiveness of triple procedure? Okay, thank you.
The second one, the effectiveness of what?
Triple procedure.
Triple procedure, like with DSEC and DMEC?
Yes.
Yeah, okay. I'll start with that one. That's an easier answer. I do DMEC triple almost every time I do a DMEC, if the patient's phakic. Because the number one reason we're doing DMECs in the United States is Fuchs dystrophy. So the patients are usually older and have the beginning of cataract anyway. And I would much rather do the cataract surgery and then the transplant than do the transplant and kill some of the endothelium when I'm doing the cataract surgery later. And so if you're phakic and you're having DMEC at Duke, it's almost always going to be a DMEC triple. I can't think of an instance where I've done something that wasn't a DMEC triple unless the patient was already pseudophakic. DMEC triple is really quite straightforward. There's just a couple interesting adjustments you have to make. For DMEC triple, you need the pupil to be large during the cataract surgery and small during the DMEC. So you don't want to overly aggressively dilate them prior to cataract surgery, such as with cyclopenolate or atropine or something that is going to be very hard to bring the pupil down. So we usually use just 1 or 2 drops of tropicamide so that we can use Myocol or something to bring the pupil down easily. And I also don't use epinephrine in the eye on the DMEC triples, which I do usually use on a standard phaco. The second thing is you have to get all the viscoelastic out. So we do most of our standard phacos with quite dispersive viscoelastics for the capsular rhexis. When because it really tamponades the capsular rhexis and makes the surgery quite a bit easier. So one we use is called Viscoat. But those viscoelastics are hard to remove entirely from the eye. So when I do a DMEC triple, I'll use Helon or methylcellulose or something that is much more easily removed so that I can make sure that I got all of it out. The last thing is when you're dealing with the bubble in the eye, it's you've got the bubble in and the graft in. The last thing you want is for the lens to pop up out of the capsular bag. So we usually make the rhexis smaller. So I'll make about a 4.5 millimeter rhexis for a DMEC triple, whereas I usually make about a 5 or 5.5 millimeter rhexis for a regular phaco. And all of those really improve the outcomes. The last thing is we also do a peripheral iridotomy for all of our DMECs. And so it turns out to be easiest for us to do that with a vitrector. So I'll just do a peripheral iridotomy with a vitrector, but you could do it with a laser before the surgery. You could do it manually. There's a variety of ways, but we make an inferior peripheral iridotomy on the triples. The other question was about the alpha core. There really hasn't been any penetrance of the alpha core into the United States, so I've never actually had one in my hands. But in reading the research about alpha core and about some of the other transplants that people have tried, I have yet to see one that has lived up to the initial hype, so to speak, meaning that you'll see some really good data come out right away, and then as they do more, it turns out it kind of works. That's been my impression of where the alpha core is, but it's kind of an unfair answer because I haven't actually used it or seen somebody use it. Overall, though, my suspicion is the Boston keratoprosthesis I was a materials engineer before I was a surgeon. I think the Boston keratoprosthesis fails because it is too stiff. And so when you blink, the stiff device rubs against the soft cornea and it eventually breaks down. And so I think alpha core and some of those are angling in a better direction. And it's just a matter of finding the one that will enable, say, epithelium to grow across the top and protect the graft from, and the inside of the eye from endophthalmitis and other things. But I don't think we've quite found the right material yet. That's my opinion. And maybe the right material is actually collagen engineering. I suspect that may be it, and just figuring out how to do that in the right way to, say, 3D print corneas or engineer corneas that way. If I had to guess, that's the most likely way that it's going to work out. But the problem with that, unfortunately, is if you're successful at making corneas that way, then you still have a cornea that can reject. I mean, if you could just make a cornea out of acrylic, that'll never reject and it'll never swell. So somewhere, I'm not sure exactly how it's going to work out. I guess if I knew how it would work out, I would just do it, and then we'd have it. But I haven't seen anything out there yet that I would say this is the thing. Yeah.
Thank you, Dr. Lloyd and Dr. Chakra. I believe there are still a lot of questions from you all, but the time is running up, and for the last, if you have more questions, you can ask Dr. Lloyd after this meeting maybe, because he's still with us. He have a lot of schedule at operating room with us today. Then before I close the meeting, maybe you have any closing remark for us?
You know, mainly just thanks for inviting me. It's been exciting to see how active and how good the ophthalmology group of surgeons is here in Indonesia. You know, coming from places like South Sudan where there are 5 surgeons in the whole country, it's been really encouraging to see just how many surgeons there are and what the high level of surgeon is. I mean, we did some transplants yesterday, and each of them I was working with a surgeon from Indonesia, and they did part of the transplant, and the skill level was very high, and it's really quite wonderful.
Thank you very much, Dr. Lloyd Berthold William. Give applause, please. Thank you all. This is the end of our lecture today. We have gained a lot of new knowledge and experience about corneal transplant and humanity from Dr. Lloyd. Thanks again to our speaker today for insightful explanation, and to the audience for all your participation. Thank you very much. Hopefully this event will be beneficial for everybody. I give it back to our MC, Melati, please. Thank you very much.
Terima kasih kepada Dr. Lloyd, Dr. Nafis. Semoga ilmu yang kita dapatkan hari ini dapat kita gunakan untuk kemaslahatan masyarakat luas. Thank you to Dr. Lloyd and Dr. Nafis. Hopefully the knowledge that we get today can be used for the benefit of the wider community. Izin menyampaikan informasi dari panitia bahwa setelah ini akan ada live surgery yang akan dilakukan di kamar operasi di Pusat Jantung Terpadu. Nanti akan ada relay di ruang operasi. Moga dokter atau bagi rekan-rekan residen yang ingin menonton bisa langsung datang ke ruang Pusat Jantung Terpadu, tempat kita operasi mata. Oke, sebelum saya tutup, saya ingin mengucapkan mohon maaf jika ada perkataan dan juga tindakan dari saya yang kurang mengenakan. Before I end this session, I would like to apologize if any of my words and action were not appropriate. So, kita akhiri acara ini dengan membaca hamdalah bersama-sama. Akhir kata, wassalamualaikum warahmatullahi wabarakatuh.
Recording stopped.